Good evening. At the outset, I would like to thank Dr. Rahul Sood, Dr. Vivek, and Biocon for this opportunity. And also, pardon me, my voice is bad because of a bad laryngitis, but I've taken special permission from Dr. Rahul Sood. He said, go on with your talk. Thank you so much, Sood sir, for this opportunity. So my topic for today is quality of life in patients with locally advanced head and neck cancer. And as we know, quality of life is a universally accepted definition. The universally accepted definition of quality of life is that it is multidimensional. So it involves with the various components like emotional, social, and physical well-being. And it is a process. So it is a subject to change over a patient's lifetime. And not only that, it is subjective. It relies primarily on the patient's own judgment. And the quality of life is determined by and impacted by several feature variables like the treatment of head and neck cancer and both acute and delayed toxicities of during radiation and chemotherapy. So the main factors affecting the quality of life who undergo CTRT include the dryness of mouth, which is called xerostomia, taste disturbance, dietary restrictions, dysphagia, and pain. Other factors reported are social interactions and depression. So as we know, there are various quality of life scales. So the commonest one which is used is the URTC1, and there are different versions of the same which we'll go on to. So this is how the C30 scale got evolved. It was the initial URTC was founded in 1962. It is an international not-for-profit organization. And then the URTC Central Office Data Center got established in 1974 and for phase 2 and phase 3 clinical trials. And then the most important today's topic, that is the URTC Quality of Life Group, got initiated in 1980, so 41 years back. And this led to the development of the URTC Quality of Life, the C30 questionnaire, which is an important instrument for cancer patients. So there are various quality of life questionnaires from the URTC. So there's something called the C36, which is the first generation core questionnaire, which was developed in 1987. And it is a 36, as the number indicates, it's a 36 item questionnaire and designed to be cancer specific, multidimensional, and appropriate for self-administration. It can be easily done, the scoring system, and applicable across a range of cultural settings. And then there came the C30 version 1, which is a second generation core questionnaire, and the first version of the 30 item questionnaire. And then there came the 30 plus 3, which is the third generation core questionnaire, which includes 33 items. And then came the version 2 of the C30, which is the interim version and retained all the original questions of these C30 version 1 while evaluating the additional 3 items. And it also gave less emphasis upon physical functioning and did not alter the internal consistency. Then came the version 3 of the C30, which differs from version 2 by 4-point scales for the first 5 items. So these are the different, basically the version 3, and which looks at various things, including the global health status, the quality of life, and then the functional scales like physical, role functioning, emotional functioning, cognitive functioning, social functioning. Even if we look at what is the definition of health, all these parameters come into play. And the symptoms like fatigue, nausea and vomiting, pain, dyspnea, insomnia, appetite loss, constipation, diarrhea, and most important, financial difficulties, which is also an important aspect in our country. Then the quality of life, the URTC head and neck 35 version 1. So basically, as indicated, it includes 35 items, including various aspects, including pain, swallowing, senses problems, speech problems, trouble with social eating, trouble with social contact, sexuality, teeth, opening of the mouth, which is very important in most of head and neck patients, dryness of the mouth, sticky saliva, coughing, feeling ill, whether the patient is on painkillers, nutritional supplements, and then feeding tube, weight loss, and weight gain, multiple factors. So this model comprises 35 questions assessing the various symptoms and side effects of treatment, social function, and body image. So most important thing about the head and neck cancer patients is the body image. And that is why they brought out these things like trouble with social eating and social contact, and of course sexuality. And the module also incorporates 7 multi-item scales and 11 single items. For all items and scales, high scores indicate that the patient has got more problems. The more the score, more the problems. This was the publication in oral oncology, basically the nemotuzumab phase 3 data, quality of life data in patients with locally advanced head and neck cancer treated with concurrent chemoradiation with cisplatin, and the other arm was nemotuzumab. I mean, the cisplatin plus nemotuzumab plus chemoradiation versus cisplatin with radiation alone. And this is basically the additional data from the phase 3 trial. And the first author is Nandini Menon. This is from the Tata Memorial Center. And you can look at the inclusion criteria. Any patient more than 18 years of age, newly diagnosed, treatment naive, stage 3 or stage 4 locally advanced head and neck cancer of oropharynx, larynx, hypopharynx or oral cavity, Karnofsky score of at least 70 or more, adequate organ function, and patients with tumors originating in the nasopharynx, salivary gland, and nasal cavity, and prior treatment with chemotherapy and immunotherapy and radiation were excluded. And the patients were randomized, good number, 268 patients in each arm. So randomized to nemotuzumab, the standard dose of 200 milligrams every week, plus cisplatin, the 30 milligram per meter square, plus radiation of 70 gray, which is the standard dosing, versus cisplatin, 30 milligrams per meter square, plus radiation 70 gray, and the patients received 7 cycles. So you can look at this, this is a very familiar Kaplan-Meier curve. The 2-year PFS was better in the red one indicates the nemotuzumab arm. You can see that the progression-free survival was much better, and it was more than actually, it was 10% better at the end of 2 years. And you can see hazard ratio was decent, and the p-value was also quite significant. And in head and neck cancer, it's also important to look at loco-regional control. Again, a very good p-value of 0.0059. And if you see here, the nemotuzumab arm as compared to CTRT with only cisplatin alone, there was a 10% difference in loco-regional control and a good hazard ratio of 0.67. And when you look at overall survival, of course, the p-value was not very significant. It was not significant. Maybe numerically it was a little higher, but the hazard ratio was 0.84. But if you look at the confidence interval, it was a little wider, and the p-value was not significant. But again, OS is difficult to demonstrate with this setting. And the DFS, if you see, again, it was better in the nemotuzumab arm, and the hazard ratio of 0.71 and a significant p-value. And if you look at the subgroup analysis of patients in HPV negative oropharyngeal cancer, there was a significant benefit of almost 25.7% in the 2-year PFS. Loco-regional control was also better by 19%. And if you look at this subgroup analysis, there was also an OS benefit of 18.6% at the end of 2 years, a very good hazard ratio of 0.63, and the p-value was quite significant. And if you look at the median PFS, again, it was almost 35.3 months versus 12.9 months favoring the nemotuzumab arm. And the median loco-regional control was also significantly better in the nemotuzumab arm. And the median OS was also better. So this is the median of all these parameters. And if they looked at the quality of life assessment, and if you look at the baseline characteristics, and if you see here, there was not, you can see the p-values here, except for the stage. There was no difference between the two arms as far as the quality of life. This goes to say that nemotuzumab did not hamper the quality of life in any way as compared to cisplatin alone in the other arm. And if you look at the other parameters, so the data was collected at baseline, 3 months, 6 months, 12 months, 18, 24, and 36 months. There was a lot of data collected, and they looked at the quality of life and also the function and symptom scales. And they looked at the quality of life, the version 3. If you look at the global health status, there was no difference at all between the two arms. And of course, if you see the change, if you see from the beginning, both the curves, if you see, they get better. This goes to say that the quality of life score gets better over a period of time once the patient completes CTRT. And if you see, there was no difference between the arm, the p-value was not significant. And the initial quality of life has always predicted, because the patient undergoes the very intensive radiation and chemo. So of course, the quality of life score is low at baseline and 3 months and improves steadily thereafter. So there were also other functional scales. So physical scale, social function, and the role function, cognitive function, emotional function, all that. If you see everything, if this is the curve for the physical function, again, scores declined during treatment, and at 3 months it was the lowest, and then after 3 months it starts improving and reaches baseline score at 12 months and continue to improve over a period of time. And after 18 months, it kind of plateaus. This goes to say that it improves over time. And other things like the symptom scale, like again, difficulty in swallowing, and if you see the cough, all these things, there was no difference between any of these arms, and so all the symptoms reached a baseline or better at 12 months. So the quality of life scores increased during the treatment as far as the H35 head and neck 35 scoring was concerned, peaked at 3 months and then declined sharply. So weight gain also progressively increased after 3 months, with highest scores at 18 months in the CTRD arm and 12 months in the nimotuzumab arm. Dryness of the mouth increased steadily during and after treatment and peaked at 6 months, and slight decline and plateau after 18 months. So basically, the idea of my talk was to say that the quality of life is an important measurement, and it has got various parameters, a very comprehensive measurement as far as the URTC is concerned. There are various versions, and it's important to know that with this molecule nimotuzumab, we have not been able to we've been able to maintain the quality of life, and over a period of time, the quality of life reaches to baseline, and before that's what it was before the treatment, and it actually gets better and better over a period of time, and nimotuzumab does not hamper the quality of life in any way. And this was very nicely shown in the phase 3 trial. Thank you so much.
So thank you so much, Dr. Vishwanath sir, for such a crisp and eloquent talk. So we still have few minutes. So any questions from the audience? Any questions, Dr. Bharat, Dr. Mandhar sir, Dr. Rahul Sood? Any question for sir? I think interesting topic and the discussions went very well. So anything?
Dr. Vishwanath, first and foremost, thank you so much, and for this wonderful presentation, despite your problems with the voice, but your husky voice added flavor to your presentation, so even better. So a very pertinent topic that you presented, Dr. Vishwanath, because the quality of life is what is a worrisome process in the head and neck cancer, and with radiation, that is what we worry about. And I think because the radiation causes a lot of collateral damage once given. And I think this is a corollary to the question I was asking Dr. Bharat, where more and more surgeons are asking for neoadjuvant therapies as well as in that. So do we see a future where probably the chemotherapy plus these biologicals may replace, I won't say replace, maybe a good option to radiation? And because look at the data you presented, wonderful data of nimotuzumab, and it's a made in India drug, so even better. So just your take on that again, once again, though you elaborated it very well.
So just to clarify your question, you're saying using all these drugs more in the neoadjuvant setting and kind of eliminating radiation, is that what you were?
So I won't say eliminate. I say it's an option which may come over a time period. Considering the toxicities are so less actually, and which is there. So maybe a food of thought for the future, probably.
I totally. That's a very interesting thought, Dr. Sood. But the only issue with the head and neck cancer is that we see a lot of local recurrence. So I'm not very sure with these systemic drugs and our wonderful immunotherapy and targeted therapies, whether we'll be able to kind of maneuver the local recurrence if we with these drugs. That is the only thought which I have.
Right.
So okay, thank you so very much once again, sir. Now we